My co-moderator, Marc Miserez, will talk about diastasis recti to open up the section.
Thank you very much. So first of all, again, I would like to thank Victor and Mircea for hosting us here in Bucharest for the 5th time. So I'm very happy that you also thought of us for inviting us to celebrate this 5th anniversary. So Victor and Mircea, thanks again. These are my disclosures. They are not relevant for the lecture, but anyhow, here they are. This is a slide I showed to you, ladies and gentlemen, a few years ago when I was asked for the first time to talk about this topic, and diastasis is really a minefield. Not only because, as you will see, there are many, many different phenotypes, but also because, as in many hernia problematics, we have many therapeutic options. For the definition, and that you see here, I will refer from time to time to the European Hernia Society guidelines on the management of diastasis that were recently published. For the definition, I show you this man with his six-pack. And of course, although we know that rectus diastasis mainly occurs in postpartum women, it's nice to see here, of course, the linea alba. And from these guidelines, we all know, and Johan said it also this morning, an interrecti distance of more than 2 centimeters is considered as diastasis. Do you need to operate every diastasis more than 2 centimeters? Of course, that's another story. What I would like to pay attention to in this introduction before the two other speakers is the wide spectrum in ladies. We can have the small diastasis based on the RHD that I just told you, with or without a concomitant epigastric or umbilical hernia. But most of the patients we see have some protrusion with some skin excess, a bit more skin excess as this patient. But many, or not many, but some of them also present with a more diffuse abdominal laxity. Some of them are obese and have a high quantity of intra-abdominal fat, and these are the dangerous ones. But because only treating the diastasis in those patients will probably not make them happy. So I will focus, of course, on the general patient we see with diastasis, but beware if you see a patient with a more general diffuse laxity, beware of just treating the diastasis and think twice. How to assess? I think we all agree on that. Comes from a systematic review published in 2016. A straight leg raise while laying flat, so a Valsalva, or a curling up. And if the patient is standing, look for a localized periumbilical or a more diffuse abdominal protrusion. And again, I will come back to that several times, try to judge the amount of skin excess. How to measure? Well, you can measure the interrectus distance at rest and curl up with the fingers, with a tape. And this is most of the time very convenient in your clinical practice. If you want some more objectivity, you can use calipers. And the repair point in general is 3 centimeters above the umbilicus. And of course, if you want more objectivity, you ask, or you do it yourself, you ask your radiologist to do a dynamic ultrasound. Especially in patients that you want to consider surgery or that you suspect of having a more diffuse laxity, you should do some cross-sectional imaging. How to classify? I will not go into detail because the next speakers will come back to that. Concerning symptoms and outcomes, this is a very important one, ladies and gentlemen, because the patient exactly comes because of core instability and even more frequent, a body image which is not satisfying to them after having 1, 2, or 3 pregnancies. So this means if we want to judge the outcome, we have to look at patient-reported outcome measures and measure that on a Likert scale. The Likert scale should include cosmesis. I think I cannot stress that again. Cosmesis related to post-op seroma, skin wrinkling, recurrence of a diastasis, or recurrence of a more general protrusion. We should look at function, we should look at pain, and quality of life. And all this should relate in a kind of a satisfaction score. So I strongly believe all this is needed if we want to look at objectively evaluating outcome of surgical treatment of diastasis. Anything on non-operative treatment, I go back to the guidelines that were published by the EHS. There is not a lot, it's moderate evidence with a weak recommendation, but they say physiotherapy might be considered before surgical management, because you don't harm. But what should we do? What should we ask? Well, first of all, from the Swedish guidelines I found, continue for at least 6 months. So while they're waiting, you could at least consider physiotherapy for at least 6 months. And what should you do? Well, from this systematic review, including 7 randomized controlled trials, where training was done for 6 to 16 weeks, again, as I told you, no adverse effects and very low quality evidence to recommend these type of exercises. Deep core stability, focusing on the diaphragm, on the pelvic floor muscles, and on the transverse abdominis, and curling up exercises, curling up training to strengthen the core of your trunk in order to decrease the symptoms related to diastasis. But, to be honest, we don't have any hard data on the long-term effect of that. So, symptomatic patients will come to us. And, of course, the crucial question is, should we plicate only or plicate with a mesh? Well, it's painful to say, but only one randomized controlled trial done by the friends from Sweden in Karolinska Institute was done, and they managed to do a trial only on 57 patients with relatively large diastasis, up to 7 centimeters, with a median of 3 to 4. And the outcome was astonishing, ladies and gentlemen, and they just published their 5-year follow-up. The 5-year recurrence rate with a very, very good follow-up is 4% in the plication group and 0 in the mesh group. Non-significant. Encapsulated seroma at 1 year, 11 versus 7, non-significant. All of them, in both groups, describe a significant improvement in quality of life, and there are no differences in quality of life, pain, or stability whatsoever in both of the groups. Moreover, from the 57, 2 patients had subsequent pregnancies with temporary pain, but no long-term disabilities after delivery. Another paper by the group of Jeff Janis from the States, he looked at a systematic review of recurrences and complications in the published literature with a follow-up of more or less 2 years. The recurrence rate in the open is less than 1, and in the laparoscopic group is 1.6. Again, non-significant. Important to note, in the open group, only 1/3 received mesh. In the lab group, almost 90% received mesh. If you looked at outcome, such as necrosis of the umbilicus, this is diastasis repair combined with concurrent hernia repair. There was a higher rate for seroma in the lab group and a higher rate for wound problems and hematoma in the open group. But not extremely big differences. And if you looked only at diastasis repair without concomitant hernia repair, there was no difference in complications whatsoever. Again, retrospective, small studies for the majority of cases. So I will come to the second and last part, surgical treatment options. Again, I went to the guidelines of the European Hernia Society and took them over. And despite the fact that the evidence is very weak, the guideline group proposes, if there is only diastasis without a hernia, go for plication. If there is diastasis with a hernia and the hernia is very small, you can remain with plication. If the hernia is bigger, you should go for mesh. But again, it's a weak recommendation. And just as Manuel said before for the parastomal hernia, this is really so much of an example of tailored surgery and shared decision-making with your patient. And personally, if I look to my own practice, I have to be able and ready and tell to my patient that intraoperative judgment and adjustment of my surgical technique might depend on the findings intraoperatively. Now, of course, I would not be here, and you know me, if I would not challenge this algorithm before I finish up. And why challenge? Well, first of all, we have no idea on what is the best plication material, how many layers, and should we use interrupted or continuous sutures. If there is skin excess, I'm a firm believer of adding together an abdominoplasty. And personally, I believe, but it's just a belief, low level of evidence, as Jan told us, if the diastasis is wider than 5, 6, or 7 centimeters, you should go for mesh. Also, if the patient has a small hernia but risk factors, I also think we should go for mesh, as we have learned in hernia surgery. But, and this will be the last things, how do these factors influence where we will put the mesh, preperitoneal, retromuscular onlay, or IPOM, but I put it between brackets, is completely unclear. So most of the patients I see, I do them together with the plastic surgeon. I leave an island of intact fascia around the umbilicus, and we go retromuscular for placing a mesh by opening the linea alba on top and below, and then combining both sides. But we are here on new minimally invasive approaches. I don't have to tell you all the retromuscular, all the onlay and intraperitoneal techniques that have been described to treat diastasis, and this is a very nice overview from Dr. Bitura in Poland. There is so much. And so I just want to highlight, before I finish up, the potential advantage of open or milus. Of course, you have a scar. The potential disadvantage of retromuscular approach is the learning curve, as we have seen, and some patients, due to closure from inside of the anterior fascia, might have a palpable ridge. Some people who have an onlay mesh have a higher chance for seroma, as we know with the Scola technique. And of course, IPOM in young ladies we try to avoid because of the intraperitoneal mesh. This is the robot and this is the onlay, of course. So let me conclude, ladies and gentlemen, because before giving the floor to my two other co-speakers, I strongly believe symptomatic diastasis should be operated by us. But diastasis on itself seems to be a different entity from the hernias because we almost don't see recurrences with plication. There are many different phenotypes, and for me, this is really tailored intraoperative decision-making. We have many, too many different options. It's often a joint venture with the plastic surgeon. Plication or mesh is, as I said to you, often an intraoperative decision. And personally, as I said a few years ago, I believe we overuse mesh in the treatment of rectus diastasis. But again, we know so little, and I'm looking forward to the rest of the discussion. Thank you very much.